As a fetus develops in utero, there is a biogenetic expectation for a specific sequence of experiences impacting the development of the brain, body, and sensory organs. When the baby's experiences occur as nature intended, the biogenetic expectations are met. Functional neuronal connections are created. Preserving this sequence creates the foundation for all future development. Providing experience-expectant input in the NICU means providing an extrauterine experience that matches the baby's intrauterine expectations as closely as possible. Mimicking the posture and sensory feedback of the womb are the foundation of neurodevelopmentally supportive positioning. Our main objectives are to learn how to provide support to posture and movement, to optimize development of biochemical and biomechanical alignment, to provide controlled exposure to varied proprioceptive, tactile, and visual stimuli, and to promote calmness, regulating the behavioral and physiologic state of the infant. Providing experience-expectant input through supportive positioning and sensory input influences healthy development of the brain and body. Each component of the typical fetal position plays a crucial role. The baby's extremities are flexed, the trunk is in a C curve with the head and neck in midline, the pelvis is maintained in a posterior pelvic tilt, the hands and arms are supported near the chest and face, the feet are held in dorsiflexion with heel pressure against the muscular boundary of the womb, and the baby can move freely, yet is always pressed back into the flexed, contained position that fosters normal musculoskeletal and central nervous system development. With this in mind, along with the goal of providing experience-expectant input, the essential components of neurodevelopmentally supportive positioning have been summarized into 5 key tenets: flexion, containment, midline alignment, 360 degrees of proprioception, and free movement with recoil. Regardless of what positioning aids may be in use, the goal of achieving the 5 tenets remains unchanged. Each video in the Positioning Pearls series will cover various ways to achieve some or all of the 5 tenets using a variety of tools and methods. Here, we will demonstrate each tenet and describe the key aspects relative to the infant's position. Supporting a flexed posture while allowing active movement into extension is the targeted outcome of positioning devices. Fetal flexion is vital to musculoskeletal development as well as swallowing, respiration, and digestion. A flexed infant exhibits the C curve typically found in the fetal position, with arms and legs drawn in closely to the body. Infants in the NICU may have varying degrees of flexion: absent, with the extremities and spine in extension; partial, where the extremities are flexed but the spine is in extension; or complete, with the extremities and spine in flexion. Containment signifies the presence of boundaries around the infant, providing an element of proprioceptive input. The uterus is a responsive, muscular boundary that provides tactile pressure input, influencing the infant into a flexed posture. Boundaries may be absent or in the bed but away from the infant, partially in contact with the infant, or completely in contact with the infant on all sides. Symmetrical movement and responses are crucial for early development and later milestone accomplishment, making it essential to reduce asymmetry. Bringing the extremities symmetrically toward the midline and keeping the head and neck in less than 45 degrees of lateral rotation promotes symmetrical musculoskeletal development for skills like rolling, crawling, and eating. A hospitalized infant may be positioned without midline alignment, with the extremities extended away from the body and the head laterally rotated more than 45 degrees, somewhat aligned along the midline, with extremities flexed toward the body and head rotated between 45 and 75 degrees, or in midline alignment, with the extremities brought closely and symmetrically toward the midline, with rounded shoulders, feet touching, and the head rotated less than 45 degrees. Proprioceptive input allows the infant to form neuronal connections that establish, to the developing brain, where the body lies in space. For example, when fully developed, proprioceptive sense allows one to eat cereal without watching the hand and spoon travel from bowl to mouth, because the brain knows where the hand is without the eyes tracking it. During gestation, the uterus essentially encapsulates the baby, providing proprioceptive feedback to the infant regardless of the way the infant moves or stretches. In the NICU, proprioceptive input can be provided at varying degrees: absent or misplaced, as the boundaries shown here are touching the baby but not in a way that provides proprioceptive feedback. Some proprioceptive input can be provided by boundaries only around the head or feet, or ideally, 360 degrees of proprioception encases the baby, ensuring a feedback loop is provided to the baby with every movement. The uterus allows for unrestricted movement and developmentally appropriate stimulation. Even though there is an enclosed space with defined boundaries, there is freedom of movement that facilitates development of proprioception. We must therefore consider the composition of any boundaries or coverings. Using tools that provide gentle but dynamic resistance, regardless of the degree or direction of extremity extension, are essential to allowing the baby to move freely within the positioner while providing recoil to a flexed posture. In the first example, a tightly swaddled hospital blanket does not allow for free movement and does not provide recoil. A simple positioning nest can allow free movement and may provide some recoil of the lower extremities, but the unsecured straps are unable to facilitate a return to flexion if they are loosened with startling. The ideal positioning support encircles the baby in a stretchy, responsive fabric covering that allows free movement and provides recoil, while promoting flexion, containment, and midline alignment and providing proprioceptive input. Each positioning pearl will discuss which of the 5 tenets of neurodevelopmentally supportive positioning are met using various tools. The clinical needs of the baby will dictate how neurodevelopmental supports can be applied, with consideration given to medical equipment, the need for visibility to clinicians, or other factors such as maintaining skin exposure to phototherapy. When we think in terms of the 5 tenets as we position our babies, we are more likely to provide robust positioning support, regardless of the complexity of the baby's clinical needs. As you move through each positioning pearl, remember, positioning strategies should be adjusted to meet the individual medical and developmental needs of each baby.